Hi everyone, and welcome to the second Pop Talk of 2020. I am Francesca Cerutti and I will be your host during this talk. With Pop Talks, we want to discuss a topic with colleagues, sharing our experiences and trying to learn something from each other. Today we are live streaming from home. Anyway, you can find us on Facebook and on Pop Dentistry YouTube channel and website. You can interact with us writing in the comments or in the live chat. So please, let's try it out and let us know where you are connecting from. Just keep in mind that if you have some questions about the topic we are discussing, you can write them and we will try to answer to you during the live event. So I would like to start introducing the guests of today. First of all, Dr. Enrico Cassai. Dr. Cassai graduated cum laude in dentistry at the University of Ferrara in 1999. He is active member of the Italian Society of Endodontology and the Italian Association of Microscopic Dentistry. He is associate member of the American Association of Endodontics and the European Society of Endodontology. And he is, of course, gold member of Style Italiano Endodontics. He's a lecturer in international courses and congresses, and he is author of several publications on peer-reviewed journals and co-author of the book Retreatments. Dr. Cassai is also a visiting professor in endodontics at the University of Ferrara. So welcome, Enrico.
Hi, Francesca, and good afternoon to all.
And then we have Dr. Marino Sutedjo. Dr. Sutedjo graduated in 2003 from the Trisakti University of Jakarta and completed his specialist degree in conservative dentistry and endodontics in 2007. He is gold member of Style Italiano Endodontics. He is a lecturer in international courses and congresses, and he leads his private dental training facility in Surabaya, Indonesia. Welcome, Marino.
Hi, Francesca. Thank you for the introductions. Hi, as well, Enrico, and hello to everyone from Indonesia.
So I would like to move to the topic of this talk, which is access cavity. So I'm sharing with you my screen in order to let you see some images together with our talk. So access cavity. This is a pivotal step of the root canal treatment. And it's very important to know how to do it and which mistakes have to be avoided. So I leave the stage to Enrico to tell us something more about it.
Well, Francesca, I'm 100% agree with you, and I tried to summarize what the literature said to us about the access cavity. And in this schema, you can see the basic steps of our endodontic treatment, starting from diagnosis to access cavity until the final restoration. And you can also appreciate that every step has to be done in the right way, in the proper way. Otherwise, we can lead at the end to problems, to failure that could happen during the time. And every step has to be done in the right way, not only, in the proper way in doing, but also just taking your time to do every step in the right way. And in my private practice, as you can also appreciate from the schema, I take a lot of time or much more time on doing the access cavity in order to avoid some problems that could happen. In fact, if we see what the literature said, a wrong cavity access done in not properly way in terms of position, in terms of extension, will not allow us to obtain results that could be predictable. So as you can see in this slide, we have two teeth with two wrong cavity access, one in the lower molar and one in the upper molar. And in both cases, we could have some problems regarding the introduction of our instrument, because we don't have an easy way to introduce the instrument, and also problem about the extensive damage of the dental structure that could modify our treatment plan, our final treatment plan. And this is true that a wrong cavity access could lead failure and problem. That also literature said us that a big portion of failure could be connected to missed canals. And you know that missed canals are one of the main points that we have to take care when we do retreatment. So when we do retreatment, the first step is to do a reconfiguration of our endodontic cavity access, as it happens in this case. In fact, in this case, I have to take care about problems on this first upper molar, where there is a big lesion in the mesiobuccal roots, and this connected to a canal that is not scouted, not finding by the clinician, and using a secondary diagnostic procedure like a CBCT, I found it. So my protocol was, once I know the problem and I have to solve the problem, do a cavity access, reconfigure the cavity access as has to be in order to find the main canals, remove the old filling materials in the main canal, clean and shape them, and then take care about the canal that is not found. And as you can see from the second picture on the slides, the inclination of the K file when I scouted is connected to the dentin triangle that is always over the orifice of MB2. So scout MB2, clean and shape, and then we can reach a predictable results in terms of working length determination and obturation, as you can see from the next slides. So only doing a cavity access proper, we can achieve this type of results, from endodontics to retreatments.
Yes, I think I'm agree with you 100%, Enrico, because in my experience as well in clinical cases daily, access cavity is a very, I think I can say it's the most important steps in our procedure. I don't think, no matter how good you are in shaping the canals or irrigating or obturating, but if you cannot find the canals through a very good access cavity, I don't think it will work that way. But I think in this time, I would like also to have a discussions about the type of access cavities, since I think we need to know what kind of type access cavity that we have at this very moment, because this type of access cavity is always evolving. As we know, many years later, we are only having the conventional type access cavity, and then it is now evolving into conservative access cavity, and it's also evolving into some ultra conservative access cavity like truce access, and also some ninja access that we all know. So I think in this time, I just want to have some very short discussions and explanations about these four types of access cavity. First thing first is about the conventional access cavity. And I think this is still the basic type that we need to, let's say, give in dental college as a basic access cavity, or the straight line access cavity, in which in this type, we usually open everything up. We remove all the roof of the pop chamber, and then we can have a direct patients into our cavity access. We can see better of the anatomical considerations inside the pop chamber. We have good maneuvering in, space for our instrumentations, and we can let's say reduce risk of missed canal and everything. This type of conventional access cavity also have some disadvantages as well as advantages. One of the case that has been sent to us by our silver member, Dr. Fitim, if you can see here, it is a maxillary first molar. And what he did with the conventional access cavity, we can see clearly all the floor of the pulp chamber, and we can identify those MB1, MB2, DP, and palatal canals. And after the obturations, you can see it's everything is manageable in a good way. But this type of access cavity, we know for sure that it will reduce the fracture strength of these two. And if we don't follow it with the proper final restorations, or let's say cups protections, eventually it will become a crack, or the worst case is a fracture like you see in this case. So that's why this type of access cavity nowadays it's considerably, let's say, we are removing too much dentin structures. And we are now arriving in this minimally invasive era where we are trying to save more and more, as much as practical, the dentin tooth structures. So that's why the second type of access cavity is the conservative access cavity. Well, this type actually is not that big difference with the conventional. We still de-roofing everything. We still open all the roof of the pulp chamber. But in this type of access cavity, we are asking to preserve more of the pericervical dentin tooth structures, but we can still have a wide enough space in order to have good visual and good maneuvering ability of our instruments. So I will share you a case of mine. This is the maxillary first molar, and I tried to do my conservative access cavity, and you can see here, I still can manage to see I have a direct patients at the floor of the pulp chamber. I can still see, identify all the canals. I can still do some good shapings in the curvature. And after final restorations on the distal area, you can see I can still manage quite enough amount of the pericervical dentin area on this tooth. So conservative, we will let's say save more. But nowadays, we're trying to be more conservative than the conservative type of access cavity. The third type, of course, is the truth access. As maybe all of us have seen this in social media, or maybe some of us have done this as well in the daily practice. This truth access is basically totally different with the conventional and the conservative, because it will not de-roof completely the roof of the pulp chamber. So we only make a hole directly into the pulp chamber that contains the root canal, but we are leaving the part on top of the roof of the pulp chamber as a dentinal bridge in order to have increased fracture strength, like the case that I did with truth access in here. I'm trying to leave the part of the dentinal bridge and maintain the, let's say, the fractures resistance of these two. And then by removing as well the stress point from the cervical to the more occlusal part area. But of course, this type of access cavity also have some risk, and you need a very skilled operator to do this type of access cavity. And after the obturations, you can still hear, after the restorations, there is still some part of the roof of the pulp chamber in the middle that we are not removed in this type of access cavity. I also have a good case as well from one of our silver member, Dr. Bartolome Caras. And as you can see, this is the same second mandibular molar with true access cavity. And he's a very skilled clinician. As you can see, he can manage very nicely done with all the curvatures and with the procedures. So I just want to discuss with all of you the fourth type of access cavity, which is this is the very ultra conservative type access cavity, or as we can say, ninja access cavity, in which in this type it is totally another difference and difficulties with the truth access. You only need to create a very tiny hole projecting into the canal, in which we cannot see completely the anatomical. You need to use a magnification and sometimes CBCT, which is, I think it's a very difficult one. I never done this type of access because I don't think it works in my hand, but I will show you some cases that has been amazingly done by Alexandru Cuica. He's also one of our silver member. As you can see, this is the ninja access cavity that has been done on the maxillary first molar. you can see the projectors at the occlusal part is very small and it's projecting into the pulp chamber, but you can still manage to find the MB1, MB2, DP, and the palatal. And as well, I think we also have one case also, the ninja access cavity from Dr. Riste, as he is also one of our silver members. And you can see here is a small, let's say a tiny access cavity that you can still manage a very good endodontic treatment on this premolar. So from this type access cavity, I think some of them has some pros or advantage, and some of them has the disadvantages or the cons. I think, what is your opinion, Francesca, for these discussions?
Well, I will try to summarize a little bit what we said up to now in order to underline the key points we have to keep in mind. First of all, conventional access cavity. This is possible for everyone who has a basic endodontic training because it makes us easier to find all of the root canal openings. In fact, from the questions that the followers are asking, one of their main concerns while doing an access cavity is to miss a canal, especially MB2 in upper molars. So with this kind of access, it's hard to miss a canal because you're seeing all the pulp chamber floor. And moreover, you have a straight insertion of the instrument. So the risk to break an instrument while making the root canal treatment is lower. On the other hand, we have an important loss of tissue with decrease of the strength of the tooth. So in this case, we have to think appropriately to a restoration in order to decrease the risk of root fracture. When we come to the truss access, as you said before, you need higher skills because you have to go straight to the point and find the root canals while preserving some dentine. So in this case, maybe you need also some more diagnostic image to know what the canals are. So maybe CBCT could be recommended in some cases. And you need, of course, magnifications. If you don't have magnification, you cannot do this type of access, which also increases the risk of making some iatrogenic damage. So we have to think carefully about pros and cons of this kind of access. Even more when it comes to the ninja. I never did a ninja access before because I'm not sure that I can take this kind of risk because I don't see exactly what I'm doing. My instruments undergo a higher stress, so the risk of breakage for cyclic fatigue is higher. So I don't think it works for me, also because you need a microscope to do this, or you're not finding anything, and maybe you need a CBCT. So it's really not for everyone, for the skills required and for the equipment required to perform a good endodontic treatment with this kind of access. Enrico, what do you think about this?
Yes, I'm completely agree with you guys. And well, I think that we have to think about new type of cavity access, or let's say move on conservative cavity access, or I will say probably a cavity access that it could be done by everyone with the predictable results.
Yep, I agree.
Yeah, sure. Also because these two last type of access cavities we discussed have some problems because the literature didn't find out of significant difference between this access and a conservative access cavity. So I don't really see the point of performing such an access. So in your opinion, how should the cavity be?
Yeah, we should find something feasible, teachable, and repeatable as our philosophy. So how should it be the access cavity that we should rely on, I think, Enrico?
Well, probably I have the answer for you, Marino, because as a Still Italiano Endodontic group, we developed, it's 2 years ago, a Stile Italiano Endodontic cavity access concept. Basically, it's a conservative cavity access with a lot of predictable results because it basically is based on anatomically guided access. It is minimally invasive approach, so we can really spare a lot of tissue, and we can modify as we need it in order to perform a good endodontic treatment. So, but I think that before thinking about the right cavity access, probably we just have to think about the difficulty that we could have doing the cavity access. So again, just take a look on the diagnostic procedure evaluation, just looking an X-ray, because it's different if a clinician should perform a cavity access by a tooth where the pulp chamber is really well present. So we have a really pulp chamber with a really depth from root to the pulp chamber floor. In this case, every clinician could trust themselves on the sensation of falling inside the pulp chamber. So probably it's an easy cavity access to manage. But if we compare this type of cavity access to other one that could happen when we have a big, for example, restoration very close to the pulp chamber floor, and in all the situation where we have a really very limited space on the depth of cavity access, so where the roof and the pulp chamber floor are really in contact between them, probably if every clinician just trusts themselves only on sensation of falling, the risk of perforation is very high. So in this case, you have to be very careful and try to look of what the anatomy suggests you to perform the cavity access. And in this case, you have also to pay attention also of the inclination of the tooth, especially if the tooth is under a crown or under a bridge, in order not to do a cavity access in an improper way. So I think that the first step is just to have a right diagnostic approach. And then again, try to use and base your cavity access design basically on these three principles. So anatomically guided access. And what does it mean? Well, the huge work of our group is just to take a lot of teeth, and for everyone just take X-ray, CBCT, in order to have from different view a nice anatomically reference that could help every clinician to do the cavity access in the right way. I would like to share with you an example. So if we take a look, for example, to a lower molar and just take a look of the occlusal view, we can see that we have two main references that are painted with a two red line, and they are the limits of our extension of cavity access. So there is a mesial limit that is done from the crestal margin that has to be maintained from 2 millimeters, 2.5 millimeters in order to prevent the resistance to fracture of the tooth. And the other one is an imaginary, for sure, red line that cut the half of the occlusal surface of the tooth. And also we have three main references that are the cusp of the mesial cusp, the mesiobuccal cusp, and the mesiolingual cusp of the lower molar, where we find along the triangular crest the mesiobuccal orifice and the mesiolingual orifice. And then we can move from our red line at the half of the occlusal view of the tooth, 1 millimeter and a half to find the orifice of the distal root, of the distal canal, in order to prevent a lot of distal structure. But also we have developed also another axis, so a vertical axis, because sometimes when we don't put the burns in the right way, we can lead to do a ledge, especially in area 1 that is identified in the draw, and this can create problems to us to insert in the proper way our instruments. So basically these are done for every teeth, but also we have to think about the possibility to change during the treatment our endodontic cavity access in order, for example, to face curved canal where we need to create a straight line access to reduce the curvature in order to reduce, also to decrease the cyclic fatigue that we could have in the curve managing with our instruments, not only KFL but also the mechanical, as it happens in this upper molar, where I have to face this very long and curvature mesobuccal canal, and in this case I perform a cavity access and extend the mesobuccal limits until the mesobuccal cusp. And for sure, this simplify the endodontic treatment in terms of scouting and shaping, but in the end, I have to modify the treatment plan and cover the tooth. And also this works also in retreatments, where, as I told you before, we have to consider to reconfigure the cavity access. In this case also, not only to find the mesobuccal 2 that was missed, but also to perform a better cleaning and shaping on the mesobuccal 1 root, as we can see from the final X-ray. And for sure, again, we pay for this aspect, at the end, we have to cover the tooth, and this is the 5 years control.
Enrico, I stop you for a second because we have a lot of questions, and people also answered to our questionnaire. And when we ask which access cavity do you prefer, 37% answered conventional, 61% answered conservative, 1% truss, and 1% ninja. So the approach of our followers is like more similar to one we have. And when we asked which is the greatest, the major issue you find while doing the access cavity, they said finding canals, finding MB2, the position of canals, so the reference point you said are maybe of use for them, to flood the pulp chamber, to remove calcification, to avoid perforation. Someone doesn't really know how much to extend with the cavity, and many find the issue of not having a straight line access to the root canals. So maybe we answered to some of these questions, of these issues. What do you suggest to remove maybe calcification and to flood the pulp chamber, Marino?
Okay, so I think I just want to address something, because usually the problems for everyone who are asking about finding canals, in my opinion, is always related to number one, how good you are creating your access cavity. And I agree completely with Enrico about the anatomical evidence, because we need to know exactly our anatomical considerations on each tooth. And diagnostic as well, one of the questions to mention is that we don't know how to extend. And I think Enrico has addressed it previously about the diagnostic evaluations. Of course, from the beginning, we need to make our X-ray in order to, we need to know how is the diagnostic of the tooth. But not just how to make a good diagnostic by doing X-ray. I think we can see the pulp chamber. And I think we can use some of the guidelines from the Krasner and Renko laws about the concentricity, symmetricity of the access design, cemento-enamel junctions area, which is the same exactly with the orifice positioning. I think if we know exactly all the rules, we will not make any perforations, because we can see clearly from the clinically where is the cemento-enamel junction area, which is in the cervical line. So just make sure we are not doing penetrations below the line, because if we are keeping the line, of course, we are not having any perforations. For calcifications, for flattening, I think, what is your opinion, Enrico? Ultrasonic tips or something you can suggest to us?
Well, first of all, I'm very happy for the question that our participants gave to us, because I think that that underline the huge work that all the Stile Italiano Odontics group had with the Stile Italiano Odontic cavity concepts, because we really can give to all the clinician the direction, the perfect direction where they can find the canals and don't miss a canal or do perforation. And secondary, answering to you, Marino, I think that we have to follow a protocol on exact protocol on doing the cavity access. And I'm glad of your question, because I would like to share with you in the next slide how I think we can perform step by step the cavity access in order not to miss also canals. And also I can answer when, in terms of times, I probably suggest to remove calcification or pulp chamber calcification if they are present.
I would like to add one thing. You two did not mention magnification and light, because you usually use a microscope while performing endodontic treatment. But we have to remember to who is listening to us that anatomical knowledge helps, but when you really can see what you're doing,
you can do it.
Another story.
Yes, of course.
If you see it, you can treat it. It was an idea. Okay, so I think we can go on. Wait.
And I also glad that majority of the followers are answering conservative type of access cavity. Because if we are looking at the evidence, of course, we know for sure many research, many literatures mentioning about the higher numbers of fracture resistance comparing conventional and the conservative. But we don't have enough data to support that ultra conservative, in which case like Ninja has a higher numbers comparing to conservative. So I think by going into conservative, I think it's just enough to maintain good numbers of fracture resistance.
Completely agree with you.
Yes. So I think you can continue, Enrico, with the slides.
Yeah, wait. Okay, we are again with the slides. So
yeah, just again, to be repeated, remember every time you do a retreatment to go and reconfigure the cavity access. Again, I'm stressful, but I think it's a very key role. And what I'm trying to say, also answering what the participant asked to us, and also the nice question of Marino, we can summarize in 3 basically steps to achieve the complete and perfect cavity access. So we just go from a preliminary endodontic cavity access, then an enlargement and a refinement. 3 steps. On the first step, we use a diamond-coated burns with a long neck to perform the cavity access, just looking at the anatomical reference points to penetrate and just to do, let's say, a prior cavity access. Then we move on the step 2, when I suggest to use a multiple blade burns with a non-working tips, in order that you can just put your tip on the pulp chamber floor and you cannot have any risk to damage it because the tip doesn't work, and you can enlarge it. And on the third steps, just take a ultrasonic tips in order to smooth all the wall, remove dentinal triangle that could be present, and for sure in this step I will remove, for example, if they are present, pulp chamber calcification. So basically, once I perform a cavity access, I just try to find, first of all, the main orifice. And then I would like to scout it, to clean and shape it. And once they are ready, let's say, to be able to obturate, I will try to find the accessory canal, like in this case, the mesiobuccal shoe, but only if the main are ready to be obturated. That is my usual routine.
Yes, I agree. I also still remember what Castellucci, one of our cult members as well, that he always mentioning Try to find your canals one by one, not just finding everything in one step. So I think I completely agree with you, Enrico. But I just also have one thought about this image. As you can see, this is a quite intact tooth, is it? I mean, we didn't see any big caries and something like or cavity. It means it's quite intact. But often in our endodontic case, we are dealing with a big cavity, and we heard a lot about caries-driven access cavity. And in which opinion you are in? Should we just remove the caries first and then find the pulp chamber, or we should go directly find the pulp chamber and dealing with the caries later? Which is your opinion, Enrico, for this one?
Thank you very much, Marino, because again you did it a very nice questions, and I would like to answer you just sharing with you a clinical case, so all the participants could follow what is my approach. For example, in this upper molar, we have to face a very huge decay, and the patient has come in my office because she has pain. So first of all, I remove all restoration, all the decay, and then I go to perform the cavity access. Well, I also probably would say that if the patient comes, for example, with a pulpitis, I will probably, my first option is to arrive as soon as I can to the pulp chamber in order to put anesthesia and to decrease the pain of the patient. And in the second time, I will clean up all the decay, but not also the old restoration. I will also remove the dentinal tissue that is not appropriate to the final restoration. So basically, I remove caries and old restoration.
You also do the same, Francesca, with this.
Consider that I agree with Enrico, but when you have to go straight to the pulp, it's important to remember that then you have to remove all the decay, because I see many treatments where the colleague maybe went straight to the pulp chamber, treated the tooth, maybe he treated it well, but didn't remove the old restoration or didn't remove the decays, and so there are bacteria all over, and it's a nonsense. So sooner or later, all the decay tissues have to be removed.
Sooner or later.
Obviously.
Sooner or later.
Yes. What do you think, Marino?
Yeah, I think agree, because I always said, judging from the diagnostic first, if it is for me, if the pulp chamber is very narrow, I think I will consider to make directly to the pulp chamber and deal with the caries and the previous restorations later. But if we still have a good space of the pulp chamber, I think we need to do what the Enrico did in this case. But I think both ways, the main point is just we need to remove all the caries, and it means we need to remove all the previous restorations. I think we have a same boat on this concept.
Yeah, I think
so. One more also, I need to ask about some questions about from both of you. Before, I just want to know what is the thinking of this pre-endodontic build-up. What is your thought? Do you need to do your pre-endo build-up first, or you don't need the pre-endo build-up at the beginning?
Okay, I answer first with
go,
some
Francesca.
images. I hardly ever do a pre-endodontic build-up because, as I said before, I like to remove all the decays and as long as I can place a clamp and keep a good isolation of my tooth, also with liquid dam, then I don't think I need a pre-endodontic build-up for several reasons, because I see better what I'm doing. My instrument has a straight line access. I use shorter instruments that in some cases are a good thing in order to achieve an easy access to the tooth. And my 4 walls container for the sodium hypochlorite is made by the pulp chamber. Of course, if I cannot manage to restore the tooth in the same appointment, or if I'm not sure that I'm seeing the patient in an appropriate time, I can think about doing a pre-endo build-up in order to save the tooth structure between the appointments. What's your approach?
What's your opinion, Enrico? Or
okay, well, I'm just, let's see, much more moderate. So Usually, I think that we have to consider two main aspects. The first is the time. Well, I try to do in my office, as you can see, I'm a fan of multiple isolation. So if I can create a build-up in a proper way, so in isolated field, and this build-up could be a part of my final restoration, well, I will do it. But basically, it's not only a time problems, because if we have to face, for example, a tooth in an anterior region where we have a really high aesthetic level, probably a build-up is mandatory after our endodontic treatment in order to put some provisional restoration like a crown. In all other situations, for example, in a posterior tooth, where I don't have so much time or my condition to isolation is not so nice, probably I just do the endodontic treatment, isolating with liquid rubber dam. And what about you, Marino?
So my opinion, I think, is a bit different. I always do my pre-endo build-up at the beginning, because in my hands, I found it in 4 walls access cavity. I can have a better irrigation efficiency, and I can have better stability of my isolation. And if I cannot finish in one visit, I can still have my good stabilization of my temporizations. But I think some of you might agree that time is, I think, is the one of the issue in this pre-endodontic build-up if we did it at the beginning. But I think that's what my thoughts on this pre-endodontic build-up.
So trying to summarize in order to give some indication, when we have a structurally intact tooth or a virgin tooth, we can go for a conservative cavity access, style Italiano access or conservative access, but just in order to save tooth structure without risking to make iatrogenic damages to our tooth. Then when we have decays, we can follow a caries-driven access. When the teeth are destroyed, if we can place a clamp, we can avoid pre-endo buildup. But if we cannot have a correct isolation, we have to do all whatever has to be done in order to achieve it. So maybe crown lengthening, surgery, gingivectomy, pre-endo buildup. And at last, in retreatments, we always have to modify our access, because probably part of the failure can be reconducted to a wrong access cavity. Do you agree, guys?
Yeah. Yes, I'm agree with this one.
Perfect.
We have a lot of questions that I would like to answer before we finish. So, for example, one of our followers asked, what is the best restoration for truss access?
Who wants to answer?
How do you restore?
Both of us. First you, Marino.
Well, of course, if asking the best, I think truss access, you can do either composite restorations or maybe some still prefer amalgam restorations. But of course, if we are dealing with truss access, in my thoughts, it means that we still have enough, I mean, a large amount of healthy tooth structures. But it doesn't mean that we need to do some indirect restorations. But that's why we will do truss access in order to just have a good amount of healthy dentin tooth structure. So I think how should we restore it is definitely just direct restorations. But the problem in composite restorations, sometimes how we get the bonding agent to manage to cover all the dentin side that we need to have a good bonding with the composite. That's why some of the let's say maybe some still use amalgam restorations in truss access because we don't need any bonding. We just pack some amalgam inside. But once again, it's just some options. But again, for me, truss access is not for daily routine because it is not something that we can do daily and every case of endodontic treatment.
So another question comes. So how do you clean the pulp chamber in truss and ninja access? Enrico, how can we manage to clean it?
Very easy. I can suggest all of these participants, don't do any truss and any ninja access. I never do. I don't want to find problem. There is no scientific evidence that this type of cavity access will bring us advantages. So don't do it. That's my answer. And for the best restoration, I will not answer about truth or ninja, but another aspect is that at the end of the cleaning of our cavity access, you have to measure the width of, at the base of the cusp in order to know if you can cut it or you can preserve it. So you have also to do a conservative evaluation.
Yeah, the thickness of sound tissue residual is very important in order to decide which is the best restoration.
I'm not so moderate like you, Marino, sorry.
And do you agree upon the fact that the floor of the pulp chamber should be completely visible? How often do we find more canals than expected? And CBCT is an option, but often the presence of metallic restoration makes its interpretation quite difficult. These are questions by your friend Paolo Generali, Enrico, so please answer your friend.
Answer is yours, Enrico.
Yeah, just summarize the question that is very interesting for sure. Well, using, I think, magnification and lights, probably we don't need to extend our cavity access, as Marino said to us when he talked about conventional cavity access. So I think that with a conservative approach like still Italiano endodontic access cavity concept suggests, we can basically respect much more dental structure compared to conventional cavity access, and see what we need to see. So the entire pulp chamber or a part of pulp chamber, but the important is that we have magnification and light. And the CBCT, well, basically I think that CBCT is a very useful, let's say, tools, especially during the retreatments. So literature said that is probably the best tools to find the MB2, but in order to also answer to the question, I think that if we know again where we can find the MB2 on the anatomic point of view, probably we don't need it.
Yeah. Correct.
Yeah.
So I think that again we have to know exactly, as Marino said before, the anatomical reference point, occlusal from vertical at the cervical point of view, and in this case we don't need to do a CBCT. Probably I will suggest a CBCT if during your treatment you have some problems in vital tooth or necrotic tooth, and I suggest the CBCT in retreatment. That for sure. What do you think, Marino?
Yes, I agree. But I just want also to answer what maybe Paolo asking about is it always the floor of the pulp chamber is clean? My answer will be no. In vital cases, yes. But in retreatment cases or some necrotic cases, the floor of the pulp chamber will not be as clean as we saw in the vital cases. So what I usually suggest, after we create an access cavity in case like that, please not to hurry to find the canals, but spend more time just to clean the cavity. We can use, for example, like EDTA, or just to just put in the chamber, just use your scaler just to clean the cavity until we can have a better visibility of the cleaner pulp chamber, then start to find the canals. That's one of my answers.
We have another interesting question about the correlation between access cavity and irrigation. They are asking if the concentration of irrigants influences our choice on the type of access cavity to be performed. In my experience, it does not, because I use the same irrigation protocol in vital, non-vital, initial treatment, retreatment. So I use always the same things. What's for you?
Same with you, Francesca.
Yeah, I agree.
So, okay. And in case of ninja access cavity, how can we be sure that all the pulp tissue are removed from the pulp chamber? We are not.
Yes, that's why you don't have to do the ninja access.
Yes.
Please stop making questions on ninja access cavity or Enrico is going to go crazy. Okay. In a destroyed tooth, even with a clamp, shouldn't we do a pre-endo build-up anyways to create a pool for irrigants?
Yes.
So do you need the restoration to have a pool for the sodium hypochlorite or whatever you use to irrigate?
Basically, probably, I don't think if Marino, you are agree with me, it depends also on the depth of pool chamber. Because if the depth of pool chamber is high, you just go with liquid rubber dam. I know that is not your proper approach, but thinking of it, probably you have enough space for the irrigants. Otherwise, probably you have to do a real pre-endo build-up.
Yeah, I agree with you, but if you ask me, then as I mentioned you before, I always do my pre-endo build-up at the beginning.
Yeah. I know.
But I know some of you might thought that if you get good deep depth of the pulp chamber and you still can do some good isolations, the flow of the irrigant still can have a nice flow inside the pulp chamber as well.
Okay, then we have a question specifically for Marino. Rubber dam first or making artificial wall, then put the rubber dam? Okay,
this is a very challenging question. So if we are talking about the best versions, of course, put a rubber dam first, then do some build up. Because we know sometimes it's a very difficult challenge if we want to do some bonded restorations in which like composite, and we cannot manage any fluid or any blood into the cavity. But sometimes also this not always possible in that type of cases. So I think once again we need to select what cases that we are dealing with. But if we are just answer to the questions, so of course, firstly, it depends on the situations and clinical cases at that time. And secondly, if you can do them first, then pre-endo build up, of course, that's the ideal situations.
Can I answer also by myself? Because I think that we have a little bit to modify the timing of cavity access in coronavirus time. So I think that one of the priority of our treatment is to put the rubber dam in order to reduce the aerosol. So probably also in this case, I will suggest you to put the rubber dam.
Yeah, I agree. And in case you have to do a pre-endodontic build-up, which is the material you prefer? Amalgam, composite, or what? In my experience, it's composite because I don't want to do things 2 or 3 times. So if I do it, it has to stay there and serve as a part of my post-endodontic restoration. The same for you guys?
I have same answer with you, Francesca. Same answers.
Okay.
Enrico?
Yeah, the same. With a good isolation, the same answer.
Okay. And will you go for a truss in a completely calcified chamber case? If yes, why? Me? Not you, Enrico. Marino.
Well, honestly, I will not do truss access. As I shared it before, that's my case I done, let's say about 3 to 4 years ago with truss access, and I did maybe only, let's say 2 or 3 cases. Then I'm stopped doing it because why? Once again, it is not for daily cases, and we will spend more time in finding the correct area in order to go directly with the with the projections of the canal. And for calcifications, it means, in my opinion, we need to see a better pictures of what is the anatomical inside the chamber. So in that case, I will not do any truss access.
Okay, and then we have 2 similar questions, and we need to have read a lot of literature to answer. So what about the conservative access, ninja access, or truss access in terms of increasing the duration or survival of the tooth? So doing a more conservative access does really improve our tooth fracture resistance. I know you read something, Marina, about it.
Yes, survival rate, it's different. If you are talking about the survival rate, it doesn't mean that we only rely on type of access cavity. We need also to rely on how much healthy tooth structures at the beginning of the treatment. We also need to rely what is the occlusion habit of the patients, what is the final restorations, how big is your post. So it is a whole different story if we are talking about the survival.
Yeah.
But what we can say in the literature, many literature, one I think I still remember what Plotino and Grande, he compared about ninja, conservative and traditional access cavity. And he can say the numbers about the conservative and conventional, of course, in terms of fracture resistance is higher. But comparing the conservative with the ninja, it doesn't have any significantly different. Of course, it has slightly numbers differences, but it is not significant. So with the not significant numbers, but we have a higher risk, I think we need to consider again. And I always think that it is better for me to lose more 1 or 2 millimeter at the coronal part rather than lose 1 or 2 millimeter at the apical part if we are talking about the survival. Because losing 1 or 2 millimeter of our working length, it can create another failures in the near future. But losing 1 or 2 millimeter at the coronal part, maybe we can do some caps protections for the survival of the longer term. So I think if we are talking only about the survival rate, I think we cannot just rely on only what type of access cavity we should create, Francesca, because it is another different aspect and a lot of aspects regarding that survival rate.
Yes,
you agree with
so
me, Enrique?
Yeah, and also there is the same results in an article that is come out in the literature done by the University of Siena, Simone Grandini, that compares the tooth access and the conservative access, and the results are the same that you spoke about the compared of ninja and conservative. So completely agree with you.
Yes.
No significant differences.
No significant
I have a public service announcement for the ones who are following us. You can find all of our webinars in Pop Dentistry. You have to go to popdentistry.styleitaliano.org/webinars, and you can see all the webinars we've done up to now. And for the upcoming webinars, you will need to register there. Registration is free. You just have to put your email and you will be able to watch them. And this will be valid for all the upcoming events of Style Italiano Endodontics. Even if you want to watch them later, it will be free. So there is no charge at all. So I would like to thank you, Marino. Thank you, Enrico, for being here and sharing this talk with me.
Thank you, Francesca.
And
my pleasure.
Thank you to all of you, and see you for the next Pop Talk.
Yes, see you
Bye.
all. Thank you for watching.
Bye, Marino.
Take care. Bye-bye.